Good afternoon, everyone. I would welcome everyone to this month's Metropolitan Trauma Advisory Committee lecture and conference. The topic today is, particularly this time of year, is kind of a sad topic in a lot of ways. We actually have to deal with this on a regular basis, which is unfortunate, but it is part of what we do. Hopefully our goal here is to learn a little bit more about how we can do what we do better, particularly from the diagnostic aspect. Our speakers today are Dr. Patricia Morgan, Medical Director of Child Protection here at Atrium Health, a pediatrician in town. She did her medical school at Howard University, followed by residency at Rutgers, correct? Yes, all right, yeah. I'm a New Jersey boy, so been there around that time. And then Dr. Mancuso is part of Charlotte Radiology here, did his internship at St. Vincent's in Worcester, Massachusetts, right? Correct? And then his residency at Dartmouth and a fellowship at Children's Hospital in Boston, and has been very integral in the Pediatric Trauma Outcomes Committee meeting, where we look at all of our major complications and mortality in the pediatric side, with specifics on his expertise on the radiology aspects of those difficult cases as well. Anyway, when you at the end we'll have a question and answer. If you could speak loudly, because these are recorded, and we're also teleconferenced to another several sites. Thank you.
Good afternoon, everyone. I'm going to adjust this mic. It might squeak. Okay. I warned you. Thank you so much for being here this afternoon, and for having Dr. Mancuso and myself to talk about an important part of the evaluation of children where there's a suspicion of abuse. And so we're hoping that in the next 45 to 50 minutes or so, that we are able to heighten your awareness on the clinical presentation of inflicted or abusive injuries, such as skeletal trauma and abusive head trauma. Again, hopefully you'll also be able to better recognize and appreciate the various imaging techniques and studies that we use when we're thinking about children who might be the victim of child physical abuse. We have the expertise of Dr. Mancuso. Very excited to have a very strong pediatric radiology team here at the hospital. So he will be reviewing radiographic findings and CT and MRI findings as it relates to physical abuse. Most of the patients are patients that have been seen here. There are a handful that I picked from another source, but the majority of those cases will be ones that have been admitted and seen through our ED and admitted to the hospital. And then lastly, we'll go over just a few mimics of abuse.
At the tone, please record your message. When you finish recording, you may hang up or press 1 for more options.
There are two common resources that are used. One is, and I have it here if anybody's interested in looking at it, it's a very thick textbook, and that's the Diagnostic Imaging of Child Abuse. There I say the Bible of imaging in child abuse cases, edited by Dr. Paul Kleiman, who Dr. Mancuso actually trained with. And then the American Academy of Pediatrics put out a statement, technical report and policy statement in 2009 on the diagnostic imaging of child abuse. So those are mostly where our information came from, and so please definitely use those as resources. So just to get everyone on the same level, we'll just go over basically what are the types of child maltreatment, and then we'll get into some cases. So when you think about child maltreatment, think about the big umbrella, and under that umbrella you have abuse and neglect. Under abuse, there are several types. There's physical abuse, sexual abuse, emotional abuse, and then under neglect, there are several types as well. For today's presentation, we will be focusing primarily on physical abuse. So no talk is complete without a few statistics, and so in 2017, according to the Administration for Children and Families, this is their child maltreatment report. So this data comes out every year, but they're about a year behind. So in 2017, It was estimated that there were about 3.5 children who were referred for CPS investigations or alternative response, so some concern with the family. And that number of referrals actually increased by 15% from the previous year, which again is very shocking and staggering when you think about children that are in need of services. But on the one hand, I like to look at it positively that these are children and families that now are brought to the attention of services and hopefully can get help to strengthen their families. It's estimated that about 674,000 children were determined to be victims of some form of child maltreatment, so somewhere under that umbrella of abuse or neglect. And that actually was a decrease from the year before. Sadly, still a large percentage of children are neglected, almost 75%, with about 18% being physically abused and 8.6% being sexually abused. And you'll see that there's no statistic for emotional abuse, but I believe that emotional abuse and emotional neglect there's so much overlap with other forms of child maltreatment, it's very hard to pull that data out. And then sadly, child fatalities due to abuse and neglect continues to be the leading cause in children under the age of 4. And in 2017, 1,720 children died either due to abuse or neglect, and that actually was a decrease from the year before. And just a quick reminder that in North Carolina, we are all mandated reporters, so all you have to do is have a suspicion. You don't have to prove a case, you just have to have a concern that this child or this infant might be physically abused or neglected. So we know that physical abuse happens across all types of communities, socioeconomic statuses, racial, ethnic groups, but there are some red flags, and I'm not going to go over all of these specifically, but just to remind you that if you have a child who comes in or an infant who comes in and they have an injury, the way we don't miss this diagnosis is by thinking about it. If you can at least put it on your differential and say, could this possibly be abuse? And then through your workup and evaluation, your history, your physical, diagnostic tests, labs, you're able to either move abuse up your differential, down, or off. But the way we don't miss these cases is really making sure that we have a high index of suspicion, especially with our infants, so less than 1 year. So speaking of index of suspicion, these are some questions that I ask myself when I get called for consultation or questions that we get from some of our regional facilities when I'm thinking about an injury. So is that history consistent? Is there no history? So if it's unexplained, I can't tell you what necessarily happened. So I have to put abuse somewhere on my list. What's their developmental level? And are they in that high-risk age group? So less than 1, that's our high-risk age group. And we know that between 2 and 4 months of age, we really start to see an uptick in physical abuse and abusive head trauma, and that's because that's when infants tend to cry a lot more. And then as a pediatrician, I am a child abuse pediatrician, but as a pediatrician, I always want to make sure that I'm thinking, could this be something else? Is there a medical explanation? So despite what people think, as a child abuse pediatrician, I really would not like to diagnose child abuse. I really would love for it to be something else. So what we're going to go over today, we're going to go over injuries as it relates to head, skeletal, chest, and abdomen. And these are some of the imaging studies that we'll be highlighting as we move through the presentation. So we'll be talking about plain films and the skeletal survey. I'll spend a little bit more time on that shortly, talking about which age group we get that. That's if they're less than 2 years of age, it's mandatory. If they have a suspicious injury or suspicious symptom, that we should be getting a skeletal survey. And I'll talk a little bit about that in a moment. CTs, MRIs, ultrasound and its role, and the bone scan. All right, so we're going to move into head injuries, and I put this picture here because I just wanted to serve as a reminder. The #1 trigger for abusive head trauma, and this is based on literature, this is based on perpetrator confession, is crying. And so what I find helpful when we're talking with families is kind of putting a good gauge so they understand that babies are going to cry and giving them tools to be able to manage crying, and understanding that if a baby cries for up to 2 hours a day, 5 hours a day if they're a high crier, that's okay if they put their baby down. So there was a PSA that came out some years ago, it's never shake, take a break, put your baby someplace safe and come back so that you don't get tempted to stop the crying by shaking. Okay, so any infant or child where there's a suspicion for abusive head trauma, we're obviously going to get head imaging. You're going to consider head imaging in looking for occult injury in infants who have bruising. So there's a mnemonic that we use, it's called 10, for faces P. So if you have an infant and they are less than 4 months of age and they have a bruise, even if it's described as small, that is an infant who needs a physical abuse workup unless you know that they have a bleeding problem or some other issue. A lot of times we're missing those cases because we consider it to be a minor injury, but that is sometimes the telltale that that is a child who's being physically abused. So these are some of the indications, again, for head imaging, and you may see these through your emergency departments or various clinical settings. And the one that I want to focus on, just unexplained vomiting, that gets a little tricky because we know that there are viral causes for vomiting, but when in the absence of diarrhea, and especially if it's prolonged vomiting, it's something that we need to at least consider. Could they have something intracranial going on? And so these are some of the injuries that you can see as it relates to physical abuse: skull fractures, subdurals, cerebral edema, cerebral contusions, cerebral hematomas, intraparenchymal injuries as well. To make the diagnosis of abusive head trauma, all we need to have are the findings in the head. Anything else that we have is corroborative. So we get dilated eye exams, especially if they have intracranial bleeding, because we are looking for retinal hemorrhages. But if they don't have retinal hemorrhages, that is not needed to make the diagnosis of abusive head trauma. Also the same with skeletal injury. When we don't see fractures, we get the skeletal survey and we don't see fractures, that doesn't mean that that child is still not a victim of abusive head trauma. All you need to have are any of the intracranial findings that are associated with that. So I'm going to just talk briefly about skull fractures, because we know that kids are sometimes left on a couch or on a table or on a bed, and they roll and they fall. So when does it become concerning? So we know that with short falls, those are falls that are less than 3 or 4 feet. Usually infants and children should not have anything, but if they do, it's usually soft tissue swelling, and they may have a linear parietal skull fracture. Why the parietal bone? It's large, it's relatively thin, and so that you can sustain a fracture there. So those are usually of less concern. Where we start to get concerned, obviously, again, short falls. So if it's a even shorter fall and they have a fracture, that would still raise a red flag for me. But where we really get concerned would be if they have multiple skull fractures, they're on both sides, they cross suture lines, they're complex or they're depressed or displaced, they're wider than 5 millimeters, so they're diastatic, and if it's another bone other than the parietal bone. Again, these are just indications that you should really pay very close attention to these cases. So I'm going to turn it over to Dr. Mancuso to go through some specific cases.
Hi. So the first image I'll show you is this 3-month-old male with a history of bruit, and was found to have a right frontal subdural hemorrhage, and I don't know if you can see the arrow will show up okay. So on the right side here, you see this hyper dense fluid within the subdural space. Normally you wouldn't see the subdural space. It's a potential space like the epidural space. Normally we would see the subarachnoid space here, where you see lower density fluid. That's normal. And here is this fluid that follows the contour of the cerebrum here. Sort of crescentic rather than lenticular or expanding the way an epidural hemorrhage might. It's not pushing in against the brain. We don't really see mass effect, and it doesn't seem. In this case, it didn't respect the suture lines as an epidural hematoma would. Initially, it will show up as on CT scan as hyperdense or bright, but later on. It may, it will over time evolve. Blood products will evolve, and it will. It may end up looking the same density as CSF, and it may be harder to see when in subacute and chronic subdural hematoma, and that's where MRI might be helpful, and we'll talk about that in a moment. But infants may present with apnea, change in muscle tone, may be cyanotic or pale, may show decreased responsiveness, and the workup depends on what your suspicions are clinically. But you may think about an abuse workup in a patient with a bruit. So in the imaging of non-accidental trauma, CT scan versus MRI, CT gives us very good spatial and temporal resolution, especially for bone. And by temporal resolution, I mean if a patient moves around, CT's fast, and so it doesn't affect the quality of the image as much as it will on MRI, where the images aren't, in most of the sequences that we use in this kind of imaging aren't acquired as quickly as CT. The scanning time is always shorter in CT, and so and because the temporal resolution of the scanning time is shorter, we don't typically need to sedate patients for CT. So that's a risk factor that you'll eliminate if you do CT as opposed to MR. But there will be a radiation dose, and a head CT, the whole body dose is something like 2.5 millisieverts now, which is maybe equivalent to an extra year of radiation living on this planet. So there's some added risk. It's probably, in large populations, it's probably measurable, but it's a small risk. But the CT does expose you to a healthy dose of ionizing radiation. And CT may, as we mentioned with the subdural, it'll show you the acute subdural, but it might not show the subacute and chronic subdural as well. And MRI may help to distinguish that. MRI is also very good for showing inflammatory changes in soft tissue, which CT doesn't do as well a job on. So here's an example of a 6-month-old born at 33 weeks with altered mental status, and the initial head CT was read as negative, and the MRI obtained the next day showed you what I was talking about. You might think there's a little bit of expansion of the subarachnoid space there, but it looks pretty symmetric, and the density is the same on the CT. But here, this on the FLAIR images, the and T1 images, this blood within the subdural space in the right frontal region is very evident, and so this is probably a subacute to chronic subdural. In the hyperacute and acute phases, days, I expect to see hyperdense fluid on CT, but as we get into more a week plus subacute and chronic, you may not be able to see the subdural hemorrhage at all on CT, and it might require MR. Another example of where MR may be helpful in the more acute phase and more helpful than CT is in this case. This is a 5-month-old born at 36 weeks with altered mental status, and the CT was negative. Although you might make the argument that there may be some generalized edema because we see pretty tight little sulci here, and so there may be some generalized edema, but it's essentially a negative CT. And on the MRI obtained at around the same time, on these diffusion-weighted images, you see in the parietal regions bilaterally and bilaterally symmetrically restricted diffusion. So on these images, the diffusion imaging is weighted to show you how free water is to move within tissue, the Brownian motion of water within cells or outside of cells. And when you see restricted diffusion, something is restricting the motion of water molecules within the tissue. And in this case, when you see it along the cortex here, it's the sodium-potassium pumps failing in cells and water becoming trapped within cells that restricts the diffusion of water, and so it shows up as bright on diffusion-weighted images. And so in the case of what we see here, an acute hypoxic ischemic injury, you may see restricted diffusion early on in the progress of the injury on MR, and the CT may be negative, as it was in this case. And so, and also to the mechanism we didn't really talk about, but the subdural hemorrhage, I mean, you've got these bridging veins that are broken. They may be broken by impact. They may be broken by torsion, by shaking, twisting of the head, with the brain moving inside the calvarium, and these veins can be broken. What you may also see with these torsional rapid twisting injuries is diffuse axonal injury, where you get parenchymal injuries where usually at their subcortical, where the white matter and cortex interface, and you can get tearing of the parenchyma. You can end up with lots of little hemorrhages and really diffuse injury to the brain. This was a 3-month-old male with vomiting and dehydration. On the initial CT, it's interesting. You could see these little hyperdense foci, subcortical foci, small hemorrhages, which suggest diffuse axonal injury. On the follow-up CT, a week later, you don't see these bright spots anymore, but you see that you're kind of losing gray-white differentiation. Like you're losing density in the in cortex here and here, and it's harder to tell the cortex from the white matter. But we no longer see these foci. And at this point, diffuse axonal injury is often better visualized on MRI. And this is a gradient echo image, sometimes called susceptibility weighted image. And what this is good for is detecting little bits of iron, as you may see within like hemosiderin, as blood products evolve. And you may see this, sometimes it's good at picking up things like cavernous angiomas, and also foci of hemorrhage that are no longer really visible on CT. And what it does is it creates this bloom artifact where you see these black spots that become bigger than they really physically are because of artifact. And it's helpful to make these things jump out for us, places where there's been bleeding and where the blood products are evolving. And this is a diffusion-weighted image, which we talked about a moment ago, of the same patient, and it shows really extensive restricted diffusion throughout the frontal lobes bilaterally. So there's really extensive ischemic injury to this brain bilaterally. It's the same patient, and just to show you that the common constellation of injuries, subdural hemorrhage. This patient also had a subdural hemorrhage, diffuse axonal injury, and here we see healing rib fractures laterally. You can see they're bulky. There's callus formation there. They're probably at least a few weeks old, and so this is a more acute injury presumably than these. So we have evidence of multiple episodes of abuse. Lateral rib fractures are maybe a little bit less common than posterior rib fractures, and with posterior rib fractures, it's a specific mechanism. They're very rare, except in cases where a person with hands large enough to go around a baby presses against presses the ribs against the transverse processes of the spine, and you get these really distinctive fractures posteriorly. And the lateral fractures tend to happen with real compression. So you can presume in a patient with normal bones that there's been a really hard squeeze when you get lateral rib fractures, because especially in infants and kids, ribs are pretty flexible. So it's certainly very rough handling. In a patient with normal bones, we see that.
Thank you. So now we'll shift gears and talk about some of the skeletal injuries. And so as in the previous patient, you saw that that patient had rib fractures. And so when should you get a skeletal survey? All right. So I apologize. I tried to make this as big as I could, but this was as big as I could get it. Take-home messages about skeletal survey. 24 months and under, you want to get a skeletal survey. The American Academy of Pediatrics and the American College of Radiologists are two organizations that have said that it is mandatory in infants and children 24 months and younger, less than 24 months, who have suspicious injuries or concerning symptoms. And so here are just a few of them that are listed there. Obviously, if we have a reported offender who confesses to shaking a baby or causing some harm, then, or there's a suspicion or concern, they should get a skeletal survey. If they're less than 12 months with bruising in high suspicion areas, and pretty much anything on a small baby is high suspicion for bruising. And then if they're less than 9 months old with bruising in the following locations, they have greater than one bruise in any location. And if they're less than 6 months, again, pretty much the whole baby is high suspicion, and so they should be getting a skeletal survey. So again, just another way, I know as adult learners we learn differently. This is just a pictogram that sort of shows less than 2, it's mandatory. Between the ages of 2 and 5, what we tend to do is focus on areas where we have concerns. So if they present in the emergency department or you see them and they have a bruise at a certain area, or they may be complaining of tenderness or have obviously deformity or swelling at a location or extremity, you're going to do focused imaging on those areas. If they're greater than 5, the whole skeletal survey is less likely. And why do we make this differentiation? Well, first of all, it's a lot of images. Okay, this is not what a skeletal survey is. This was a patient who came to us from an outside hospital, and they said, oh, yep, we did the skeletal survey. And what they did was they put the film under the baby. If you look, it looks like they're actually walking this baby through the park or something. The adults are holding. It's so wrong in so many ways. It is actually 21 images when you include the oblique films that we do here at our institution. And so this is a list of all the imaging, the films that are actually taken. And that is not what it should be, okay? So the skeletal survey, other considerations if we have multiples, so twins, triplets, and we've had cases here of twins and triplets where the index baby came in, found to have rib fractures or some skeletal injury, and we brought the other siblings in of that same birth, and they also had injuries, sadly. Severe neglect has also been an area that's being studied to see if we should be doing skeletal surveys, and right now I think in really only cases of extreme neglect is it recommended to get a skeletal survey. In the cases of sexual abuse, it's really not necessary, but you are going to get DSS or YFS workers who are going to come into the emergency department, and they're going to bring a 7-year-old, and they're going to want a skeletal survey, to which you will say, no skeletal survey, right? So remember our ages. In 10 to 14 days, we usually recommend getting a follow-up skeletal survey, especially if we have a high index of suspicion. The first skeletal survey was negative or they had equivocal findings. We're going to get that follow-up skeletal survey. What we did here at our institution, in speaking with our fantastic pediatric radiology group here, we decided that it's radiation. And so we wanted to be very mindful about that. And so we decided to exclude certain images, and it cuts the radiation down by almost half. So on the follow-up skeletal survey, we are no longer getting the spine, we're not getting the pelvis, we're not getting hands and feet, and we're only getting the skull if there was a skull fracture on the initial skeletal survey. So again, just so that you understand that we are being very mindful in how we're imaging children here. So a lot of times when I'm asked by law enforcement or DSS about when did it happen, because they're trying to narrow that time frame down so that they can identify who may have hurt that infant or that child, we use all sorts of things to try to help us, how that infant or child was doing clinically, when were they last well, but then radiographically, there are some indications that help us to narrow the time frame down. So we know that within those first few days, we may see soft tissue swelling, soft tissue findings up to 3 weeks. Periosteal newborn formation is estimated that starts about 4 days to 3 weeks, and this is from Kleiman, that book that I was telling you about. Callus formation, about 10 days is when you start to see it, up to about 13 weeks because it goes through a soft callus and a hard callus. I'm not a radiologist. I play one on TV, so I'll have Dr. Mancuso chime in if there's anything that is different or he wants to add. And then remodeling. By the time you're seeing remodeling of that injury, it's been about 3 months. So this is a handy chart that we use. There is no fracture type that is pathognomonic for child abuse, but there are fractures that are highly specific. Whoops. And we're going to focus on those for the next 10 to 15 minutes or so. So metaphyseal fractures, rib fractures, especially those that are posterior and or multiple, scapula, the 3 S's as I call them, those are the ones that we'll be focusing on. The other ones have lower specificity or moderate specificity, and in those instances, you really just want to get a good history. And if they don't have a history and it's an infant and they have an unexplained fracture, we have to think about physical abuse. Minimally, that's neglect, right? If you have a 4-month-old that has a fracture and no one can tell you how it happened, minimally that's neglect. So it still warrants the same concern. And so with metaphyseal fractures, the way that the mechanism of injury with metaphyseal fractures is either by shaking or pulling of the extremity. And what you see is sort of micro fractures towards the metaphysis. And again, I'm going to definitely defer to Dr. Mancuso to expound on some of these. But this is an old picture. I use it a lot because it sort of just gives the illustration of yanking of that extremity or pulling of that extremity and what that looks like in a drawing, causing the avulsion of the metaphyseal area, and then radiographically what that looks like. Again, if you hear the term corner fracture, chip fracture, bucket handle fracture, those usually are referring to metaphyseal fractures. They're highly specific for inflicted trauma. And so here's a diagram of what that might look like, and then radiographically it looks like a bucket handle. Dr. Mancuso, do you have anything to add on any of these?
You're doing a terrific job.
Okay, and then again, showing just another example of there are some normal variants that happen towards the metaphyseal area. There's step off, there's beaking, things like that. But if you see an actual fracture line with this chip, that needs to raise all sorts of red flags for you that this is from a shaking or pulling of an extremity. And if you don't get the right history, a history that makes sense with that, this is an infant or a child who needs further evaluation and workup. So as Dr. Mancuso was explaining earlier with rib fractures, people think, oh, they're babies, their bones break really easily. Actually, it's not true. With rib fractures especially, what's going to happen because of the nature and the composition of bones of infants and children, those bones are going to bend, and then they're going to break. So based on perpetrator confession, those who've said, yes, I shook the baby and it was a very violent act, they're squeezing that chest. And so you're seeing these fractures posteriorly. That's why they're so specific. If you look at where, I'll use this. If you look at where the fingertips are, so here's the back, here's the front, so anterior, posterior. Here are where fractures would occur. So look at the pressure of the digits there, and then as that force is sort of moving around here and they're squeezing, so it's a compressive force, you end up with fractures laterally. And there's tons in the literature that talk about CPR not causing rib fractures, MVCs not causing a posterior rib fracture specifically. Okay, and just one study, it's an older study, but it's referenced a lot, showing that the positive predictive value of posterior rib fractures being associated with abuse is about 95%. And Dr. Mancuso.
And we talked about the value of follow-up skeletal surveys, and this is just to illustrate how they can be helpful. Here's a 13-month-old female with a negative initial skeletal survey, and on the follow-up skeletal survey, here we see some new bone formation, focal widening of the rib, so there's a healing posterior fracture, which we couldn't see on the initial X-ray, and because of the mechanism, oftentimes there are non-displaced posterior fractures, and unless you catch them just right in the right obliquity, you frequently can't see those fractures until there's some healing. And that's one of the reasons that we'll do. One of the reasons that follow-up skeletal surveys are so important. And as Dr. Morgan had mentioned, you expect to see within a couple of weeks evidence of healing in an acute fracture, and so that's why we like to time the follow-up survey about 2 weeks after the initial survey. I think for me, head CT and skull radiographs are complementary when we're looking for skull fractures. They're not, one doesn't really exclude the other. I think there's been In some cases, we don't get skull films usually from outside institutions. If they've done a head CT, they think, well, we've done a head CT, why bother? Depending on how much motion artifact there is in the head CT and also on the orientation of the fracture, you might not be able to see it very well on the head CT, especially if it's sort of in the plane of acquisition, if it's sort of at an axial kind of plane of fracture, and it may be very evident on the skull radiograph. And alternatively, especially with posterior and occipital fractures, the lower they are, the harder I think they are to see on plain film sometimes because of all the superimposed structures. CT may be helpful, and here's just an example of an occipital fracture that we see here, and this is the lambdoid suture, but that's not a suture. That's a fracture with a little bit of depression, and it's something we didn't see on plain film, but we did pick up on CT. And as Dr. Morgan had mentioned, these 3 S fractures are very specific in infants for abuse, fractures of the scapula, fractures of the sternum, or spinous processes of the spine. We'll also see sometimes, always look for compression fractures of the spine, which you can see if an infant has been slammed roughly down onto a surface, you get an axial load, and you may end up with compression fractures of the spine. To talk about bone scan a little bit, this is a patient, a 3-month-old with bruising after a fall, had a tibia fracture, and these, you can see healing rib fractures here, or there's some callus formation laterally. What's harder to see is this. There's an acute posterior fracture right there where the arrow is, and I don't know whether this was seen initially. It may have been seen initially on the original scan, but it's the patient ended up getting a nuclear medicine bone scan, which the mechanism of uptake isn't entirely understood, but it does when there's healing of bone and production of new bone. The radiotracer is taken up by the osteoblasts, and let's see if I can my arrow back. So we see here's the tibia fracture. This is I think where the patient was injected here, and here there are a few little foci. That's a posterior image, so this is the left side, and those, at least one of them corresponds to this acute fracture. And nuclear medicine bone scan can show fractures. It's pretty sensitive for fractures. If we see an abnormality, we have to follow it up with plain film to try to confirm it. So the specificity isn't for certain fractures isn't as good as radiographs, but in many cases, the way I view it as a complement for plain films, and if it's a question, gee, I think this might be a fracture, but I'm not entirely sure. Sometimes a nuclear medicine bone scan can really increase your confidence of the diagnosis of a fracture. Not so great for corner fractures. Why? Because, well, the bone's growing at the growth plates, and the growth plates light up on bone scan because of bone growth there, and sometimes it's hard to distinguish that from healing fractures at the ends of the bones. But it's good for rib fractures. Not so great for skull fractures either, because the squamous bone of the skull heals in a different way, and we don't typically see the healing skull fractures on nuclear medicine bone scan when they may be very evident on plain films. There's also, I think, in terms of dose, a skeletal survey, I think the dose is about like 0.2 millisievert, and a nuclear medicine bone scan is more like a CT scan. It's more like 2.5 millisievert, so it's maybe 10 times the dose. And you're talking about the difference between like an extra month of exposure on this planet and an extra year between a bone scan, between a skeletal survey and a nuclear medicine bone scan or a CT. So just an example of a diaphyseal fracture. You've got actually, this one's kind of really at the metadiaphysis, and you can see periosteal reaction along the bone, so there's healing, and it's probably at least a couple of weeks old, at least 10 days or so. and this one's transverse. And so transverse fracture can result from a direct blow or an axial load, as opposed to spiral, which is the result of a twisting motion, or oblique, more of a bending motion. Brings us to chest injuries. Okay. And the internal thoracic injuries may include contusions of the lung, pneumothorax. The signs might be hemothorax, pneumothorax. You may see rib fractures. You may see cardiovascular injuries. This is a patient that presented, a 2-month-old, presented with drooling and gagging on secretions in respiratory distress and decreased breath sounds bilaterally. Was found to have an esophageal tear on CT, but here you can see there are bilateral pneumothoraces and also some pneumomediastinum. You can see here posteriorly, kind of surrounding the esophagus. So these are radiographic signs of esophageal injury. All right, turn it back over to Pat.
Okay, so now we're going to move on to abdominal injuries. And one of the big take-home messages I like to leave folks with abdominal injuries is that if you base your index of suspicion on whether or not there's bruising anywhere on the thorax or the abdomen, in the overwhelming majority of cases, you will not see any bruising on an external or skin exam that will indicate that this child has possibly been a victim of abuse. So that even requires that we have an even higher index of suspicion. So this picture is not typically what you're going to see. You're going to see nothing in terms of bruising. You may have a different abdominal exam, but looking for bruising to think about abdominal trauma is not going to necessarily give you the information that you need to decide whether or not you want to do more. But when we think about abdominal injuries, we have hollow and solid organs within the abdominal cavity, and so you can see contusions and lacerations involving the liver. You can see duodenal or jejunal injuries or hematoma or lacerations, pancreatic involvement, splenic contusion, splenic lacs, and renal involvement as well with similar injury patterns. And so when we look at intestinal injuries, we can see that based on this one study, and this is again from Kleinman, that 30 to 60% to 10% looks at the distribution of where you'll have injuries of our hollow viscous injuries. And if you can imagine that this is blunt force trauma or direct impact, this gives you a depiction of what potential organs can be involved when we look at our more solid organs. And so Dr. Mancuso is going to tell you about a case that we had here. And this patient, I think probably in all the years that I've been doing this work, had the highest elevated transaminases, 3,000 and 2,000 for this little one.
So the patient initially had an ultrasound which showed this large amount of complex fluid in the pelvis. And by that I mean it's got internal echoes. There's something in it's not simple fluid, and so you worry about hemoperitoneum, even possibly a perforated viscus. So the patient needed a CT, which showed. Here you can see these areas of kind of linear areas of decreased density within the liver, which is a laceration, and you can see around the liver and around into the anterior pararenal space here some hyperdense fluid, which looks like blood. In addition, this patient had a healing. Another earlier injury, a healing fracture here of the distal transverse non-displaced fracture of the distal left ulna. So another patient with injuries of different ages.
The challenging thing with a lot of these cases, and this one in particular, this little girl looked fine. She did not have any abdominal bruising. Unfortunately, because there were two different ages in terms of her injuries, and she had multiple caregivers, was in two different homes with multiple people taking care of her, they could never identify an offender for this little one, which unfortunately is the case in a lot of these situations. So in closing, we're going to just talk about a few mimics of abuse. So these are cases of patients who came here. They had an injury. We did the workup for non-accidental trauma or for physical abuse, and they had another diagnosis. So in looking at the differential, this is not an all-inclusive list. It would take several slides to really go through the differential for intracranial findings and skeletal injury, or skeletal findings, I should say, that are on the differential for abuse. But big picture, think about non-inflicted or accidental injuries. We know that they do happen. We know that kids do roll and fall or get dropped from certain heights, and we know that kids run and fall and may have a skeletal injury. But these are just some of the other differentials based on intracranial hemorrhaging or skeletal injury. So we're just going to highlight and focus on three patients, and again, these were patients that were here with us. Oops, that was not the right, whoa. Close your eyes. Okay. Oh, shucks. This is why I don't use the laptop. Okay, I'm going to let you advance it.
Okay. And so this patient is an 11-month-old male dropped by the 8-year-old sibling, and the sibling landing on the patient. And that's the kind of story I want to hear if I see a mid-shaft femur fracture. It's an infant. They can't inflict this kind of injury upon themselves, but if an adult's carrying, they fall down the stairs, they land on them. That's the way these things can happen accidentally. So the story is reasonable. And then this patient, though, had really abnormal metaphyses. And you can see here is a good example of what we call cupping and fraying of the metaphysis. And it's there's a differential, but it's characteristic of rickets, of vitamin D deficiency rickets, which may, so these metaphyseal, sorry, lost my laser, but the metaphyseal abnormalities can mimic a healing corner fracture when you see them everywhere, and sort of symmetric, especially with this feature where it's really like cupped out metaphysis that's really characteristic of rickets.
So this patient that Dr. Mancuso just showed you, their vitamin D level, and we will routinely get a 25-hydroxy vitamin D level with these patients. His was 6. The lower end of that is 30. So he was vitamin D deficient and found to have vitamin D deficient rickets with a history that was consistent. One of our child abuse doctors happened to be the attending inpatient, and so she felt like it was a consistent history, and he got treated for his vitamin D deficiency. And so just a little bit more information. We're running short on time, so I just want to quickly go through just in terms of labs. You have low calcium along with that, and the parathyroid hormone, PTH intact, will usually be high, and this patient also had that. And you may also see signs and symptoms as it relates to hypocalcemia or proximal muscle weakness. And then the treatment is vitamin D, and there's a wide range, and it varies in the literature what you should use. So as long as you start to see the numbers go up, you know that you're on the right path. This patient actually got placed on 5,000 units IUs per day. A month later, his vitamin D was 50. So he made some strides, and then he went over to his PCP.
So osteogenesis imperfecta is another potential mimic of child abuse. And here you can see, here's a healing lateral fracture. There's another one on the right side. But the ribs are really gracile. They're really thin. The long bones are thin. Oftentimes they'll be sort of bent in kids with osteogenesis imperfecta. These are patients that can end up with with lateral rib fractures accidentally. But osteogenesis imperfecta isn't protective against child abuse, so it's a difficult situation for the clinician when you see a patient like with bones like this that has healing rib fractures.
So when I was in medical school, there were 4 types of OI. Now there are 19 recognized types. And so defense medical experts really like to have a field day with osteogenesis imperfecta if you even mention that they have blue sclera, which can be a normal variant in kids who have iron deficiency, or just because of the nature of the sclera, they can have a slight bluish gray tint. So defense medical experts love this diagnosis. Ones that get confused with child abuse are type 1 and type 4, where they don't have blue sclera, but some of the other forms are so severe that they're lethal. They die shortly after birth. But things that we'd be looking for besides the blue sclera would, again, there would be radiographic findings, usually that they have osteopenia or some other changes. They may have worming in bones in their skull. They may have easy bruisability. And then the family history may or may not be positive, because there are so many spontaneous mutations, which is how we've now ended up with 19 types. You may or may not get a family history of things that we would see: hypermobility, deafness, short stature, and then the fragile or translucent teeth. And then we diagnose it hopefully either clinically, but usually we end up having to do DNA sequencing to look for collagen mutations. And then you get a defense medical expert who says, well, what if this is a mutation that has not yet been identified, just to make things interesting.
Another possible mimic is Caffey's disease, or infantile cortical hyperostosis. This is a 4-month-old patient who presented with right arm swelling, and you can see the ulna is really, really thick. Radius is kind of thickened too. You can't find a focal fracture, but it was initially interpreted as probably healing fractures with a lot of callus, and then the patient got a skeletal survey which showed amazingly thickened ribs, bilaterally symmetric everywhere, and also the mandible is quite wide, like from here to here. That's maybe 3 times thicker than a normal mandible, and so these findings were highly characteristic, classic for Caffey's disease, especially the specific involvement of the ulnas bilaterally and the mandible. I think the geneticist didn't really agree with this on this patient, but it's still a textbook case of Caffey disease.
Yes, I agree. I haven't seen many of these cases, but I think just when you look at all the things that she had, and what ended up keeping her here in the hospital longer was feeding. So the mandible and the jaw, very painful. She had to have an NG tube placed to give her get her weight back up, but eventually was able to start taking PO well and was discharged home to the care of her mother with no concern for abuse. But she did get the abuse workup, because again, we always want to just make sure that we are not missing any cases. But as Dr. Mancuso mentioned, cortical thickening, and it's usually the mandible, but it can be the clavicle, it can be the ulna, and we usually diagnose it within the first 6 months of life. There may or may not be a family history, and there may not be any other associated fractures or irregularities at the metaphyseal area. So we've talked a lot about imaging, different types of imaging, and just to make sure that we are all aware that we do image gently here. I think that we try not to do excessive tests, radiographs, or other types of imaging, just because we try to be very mindful, which is why we changed our policy some years ago to cut the radiation in half. So thinking about our technique, shielding patients, and then always using our pediatric radiologists as support and consultation if you're not sure about which study, especially when we're talking about radiation. And in closing, just want to make sure you all know that we are here. The child protection team, we have 4 or 5 medical providers. Dr. Kendra Ham is a child abuse pediatrician. She's here 3 days a week. I'm here all the time. Dr. Noonan and Dr. Rogers continue to work with our team and help us with cases. And we are available 24/7, 365 through HALO. If you HALO LCH Child Protection Team or Child Maltreatment, that we used to be called Child Maltreatment, we're now calling ourselves Child Protection because we're trying to protect children. We are available to answer questions if you have concerns. And then our fantastic pediatric radiologist, Dr. Mancuso, do you want to say anything more about your team?
We're continuing to expand coverage. We actually have another member, Dr. Dr. Hendy, who's an interventional radiologist who's also covering pediatric diagnostic radiology. You should be able to get hold of a pediatric radiologist anytime. In some cases, it may be in evenings. We still have a team in Denver, a pediatric radiologist that covers teleradiology, but you should be able to consult with them about child abuse cases. Call the ACA at 355-6644 and let them know you need to speak to a pediatric radiologist. I think as our group grows, we're planning to extend evening coverage and a more extensive pediatric call with local pediatric radiologists. And that's our hope, is to get closer and closer to 7/24, 365 coverage.
So have a high index of suspicion. Remember that children are still very susceptible to abusive head trauma, physical abuse being the leading cause of death. Imaging is a very important part of our workup. There are mimics, and we are here to help. And we have a few minutes for questions. We thank you so much for your attention and the work that you do. Thank you so much.
Dr. Morgan?
Yes.
For the $4.1 million that we had, your first slide mentioned, like 675,000 confirmed. How much do you think we're missing and not capturing?
So that's a great question. So the question is about the 4.1 million that have CPS referrals and 674,000 or so that are actually confirmed to be some form of child maltreatment. It's estimated that we are missing about 3 times that number in terms of referrals. So the number of calls that get made to CPS for either a referral or some type of alternative response, they think that the number of cases is actually about 3 times higher. So it's out there.
And then you said something about, was it 4-month-old and younger with the bruising?
So 10 for faces P. So T is for torso, E is for ears. There's a whole mnemonic, but 4 is for 4 months and under, and then also if they're under 4 years of age and they have bruising in any of the high suspicion areas. Other questions?
Dr. Christmas, our Associate Pediatric Trauma Medical Director, any thoughts?
Yeah, I think like I said, it's the high index of suspicion, and they're even going to be the ones that come in and this story may sound completely legitimate, and I had one of these a week ago that was child dropped, sibling caught it by the ankle, and have a chip fracture, right?
Mm-hmm.
And so by the word of kind of the rule, if you will, it seemed like it was all reasonable, but you never know when somebody's going to have a moment when they snap and do something to a child. So it's our responsibility to do due diligence to these kids and make sure we get the work up. You're better to overcall than to undercall, and then next thing you know, you'll have on your mind a potential dead child a few months from now when you find out it really was.
That's an excellent point, Dr. Christmas. And again, we're not pointing the finger. It's just if you have that suspicion, and that's all it needs to be, is you need to do the right thing for these infants and children and be their voice because they can't speak for themselves. Dr. Seckler.
I was going to add on to that. In my experience, where there's a yellow or red flag that comes up, it's thought about, but evaluation is considered within be not needed. And then down the road, tragedy hits. One of those, in the follow-up to those events, the most common thing I've heard that links them is that their family was so nice. They were, with that sort of the unspoken, they were just like
Right. That's another very excellent point. I'm actually working on a presentation, and it's titled "The Family Was Appropriate," and it's cases where it was a nuclear intact family or whatever the things were that they seemed so nice, and of course they wouldn't abuse their child, and then these children, all these infants and children in the case series that I'm presenting on, all had injuries that were suspicious for abuse or consistent with abuse. So thank you for that point, Dr. Seckler. Any other questions, comments, thoughts? Yes, ma'am.
Are there delayed issues of cognitive learning and things like that for the child, or what they receive treatment? Do they?
Well, it really depends on how extensive and how large it was, because some of these kids do totally fine, which is why we see acute and subacute findings, is that they don't always necessarily come in and have issues. I think we really tell once they hit school to see if there are any limitations in terms of cognition and if they had anything besides subdural. So if they had cerebral edema, or they had, if they have hypoxic ischemic injury, really we won't be able to know more until they start school and we see some of those issues. So what we recommend when they get discharged is we recommend early intervention to try to catch some of those possible deficits, whether they're cognitive or motor, based on their intracranial injury. We try to capture those early on and get them the help that they need. Did that answer your question? Okay. Anything else? Thank you all so much.